Yes, Dr. Chandra, you can start.
Yes, sir. Good evening, everyone. I welcome all the members of KSCASI to this webinar, an interesting topic on how to conduct the journal club. So we have stalwarts in the field of this, Dr. Rajesh Ballal, who is a present professor in KMC Mangalore and also the executive committee member of KSCASI. So, and we have faculty, Dr. Ramakrishna, President of Bhadravathi Surgical City Branch, and Dr. K. Lakshman, sir, who is a consultant laparoscopic surgeon in Sagar Hospital and a DNB teacher. So, and I request everybody to mute except the presenters. And I request our chairman, Dr. H. Shivaram, to formally welcome.
Thank you, Dr. Chandrashekar. Dr. Chandrashekar is our very active, dynamic honorary secretary. Journal club is a very, very important activity, not only for the students, but also for teachers. And how to conduct journal club and how to extract the knowledge from the vast number of journal articles is an art. And this art is basically taught to us by Dr. Lakshman, Dr. Ramakrishna, and so many others, Dr. Shanai and all. And they are very well versed in our state about this. So we have roped in the fantastic faculty for this activity. I'm sure all of you will be gaining a lot of knowledge out of it. And this is a very, very important scientific activity. If you see, there are about more than 30,000 scientific journals. And in surgery alone, there are more than 5,000 journals. And each journal, every month, they produce articles. How to select them, how to read what is required for us, it comes only by critical appraisal. And that's what the exercise we are going to do today and learn. And I am thankful to all the faculties, students, HODs who have logged in and who have motivated others to log in. Already there are 89, 90 people. I'm sure we will have excellent participation. And with these words, I will leave it to the faculty to take on the further. Thank you very much, Dr. Mehnaz, a student from Bangalore Medical College, for accepting to present also. Thank you, sir. Please take the...
Good evening. Good evening, everybody. At the outset, on behalf of myself and our esteemed faculty, Dr. Ramakrishna, Dr. Ballal, and a very enthusiastic and very bright postgraduate student from BMC, Dr. Mehnaz, I would like to thank the KSCASI for giving us this opportunity. The essence of good surgery is evidence-based practice. And to evaluate a given piece of information, be it a journal article, be it a common write-up, be it a chapter in a book or whatever that we read, to evaluate it, we need to have the skills of critical appraisal. And journal club is a classic conventional teaching tool which teaches all of us the skill of critical appraisal of a given piece of information. Most of the time it applies to a journal article. And at this juncture, I would strongly urge our postgraduates to develop the habit of going a step beyond textbooks. Textbooks are very important. I'm not at all belittling or undervaluing the value of a textbook chapter, but it is not enough as a postgraduate to be restricted to reading in a textbook. You have to go beyond a textbook, read relevant journal articles, and have the skill to critically apprise and agree, disagree, modify, or whatever with the contents of a given article that we are apprising. So hopefully this evening exercise will give you an introduction and perhaps a bird's eye view of what is done. I'm delighted to have a very esteemed faculty with me today. Dr. Rajesh Ballal will to give a short presentation about the ethos or a philosophy behind a journal club, how it is done, how it is prepared, and what is done. And later on, Dr. Ramakrishna will take the lead in getting the discussion going on the presentation of a critical appraisal that Dr. Manas will give. But as we have always been saying, even in the build-up to this event, it is important that a journals club will be worth the exercise only when we have inputs from the members of the journal club. Today, we are just see a number 100 on the participants. We have 100 people participating. Most of the time, it will be a small group of maybe 10 to 30 people. But your inputs on getting the comments in is extremely important. So I would request all of you, when the time comes, Mahanas will give you the opportunity to put your comments in or vocalize your comments. Please raise your hand, and when called out, unmute yourself and you can kindly give your comment out. If you hesitate to vocalize your comments, you're welcome to put it in the chat box. I and my colleagues will be monitoring the chat box and we will take up the questions from there as well. May I now request Dr. Rajesh Ballal to share the screen and give us his presentation on the conduct of a journal club. Rajesh, please.
Thank you, sir. Thank you. Very kind words, sir. I must also thank my president and the secretary of the ASI for giving me an opportunity to speak to an audience like this. Special thanks to two of my mentors, Drs. Lakshman and Dr. Ramakrishna says. They did what is called the classic critical evaluation. They looked at my presentation. They not only modified it, but they were also kind enough to let me share a few of their slides. Just give me 1 minute. Yes. Is visible? Am I visible, sir?
No, Rajesh, not yet.
The presentation is not visible?
No, not yet, Rajesh.
No, sir.
Would you like me to share the screen, Rajesh?
Please, sir, please.
Okay, let me try. Can you see it now?
Yes. Yes, sir.
Sir, can you go to the PPT view?
I
I'm
can't
doing
see,
that. I'm doing that. Yeah, there you are.
I can't see, I think, sir.
You can't see the slides?
Yeah, I can see only my slides. I don't know if it's synced with. Have you put slides share, sir?
I put a slide share and now the slide is showing organize as the first item or the
No,
second
that's
slide.
not the one. Yeah, I'm trying to 1 minute. Just a minute.
And the rest of you see the screen?
Yes, sir. It's visible, clear.
I'm not able to see, sir.
All right.
Rajesh, you stop sharing your screen
I've
first.
stopped. I've
You
stopped, sir.
stopped.
Again, you share.
Okay, I will stop sharing now
Okay, sir.
and you try it again and see what
Let me
happens.
see. Yes.
Yes, we can now see your screen, Rajesh.
Not able to share.
No, you had shared it. You
Yeah,
just
it
had
was
to
open.
click.
It was open. Then something happens. Just a minute. Give me a minute.
Just click on the Journal Club 13th. Yeah.
I'm trying. This one is on my desktop.
No. Yeah, just double click that. You got it now. It will open now.
Is it
Yeah, there you
visible now?
Yeah,
Yeah.
visible
Yes, sir.
now. Visible
Okay,
now.
right.
Go to full
Fine.
screen and you're
Fine.
on.
Yes, yes. Just a minute.
Down.
Is it visible, sir?
Yeah, it's
Yes,
fine.
sir.
Now.
Yeah.
Please go ahead. Yeah.
Extremely sorry for this technical glitch. Probably journal clubs also are like this, I think. You know, many colleges, things like this happen. So I'm sorry, this is my computer illiteracy. like I said, I'm extremely thankful to two of my mentors, Doctors Lakshman and Ramakrishna sirs. A few of their slides I borrowed from them with permission. That's also important when you talk of a journal. You must talk of the source of your information. So let's look at it for the next 8 to 10 minutes. And I say that this is like a trailer. The main cinema is from the postgraduate. And I must confess, she's a very brave girl, because looking at the stalwarts in this meeting, I as a postgraduate would have been extremely scared, but then times do change. You look at the basics of a journal club, it's only 3 actually. You organize, you prepare, and present. You decide when you want to present a journal club, and hopefully prepare adequately and then present well. This is the gist of what you're supposed to be doing. If it were that simple, we wouldn't be having a meeting like this. My screen is not moving.
Just go back and then again.
No, click again, left click again on the slide, it'll come. It'll jump between the Zoom screen and your PPT screen. Just click again, left click on your screen and click again, it'll go.
Everything trying, sir.
Okay.
Give me 1 minute. It just stuck. Yes, okay.
Yeah.
Right, sorry. There are certain formats in a journal club. What we usually do is what is called the traditional format. It's not moving, sir. It's not moving at all.
Okay. Can I try sharing and see if you can hopefully see the screen?
Yes, yes,
again?
sir. Yes, sir.
Because I had yours as yeah. Just stop sharing.
Yes.
Otherwise,
Stop
Lakshman,
sharing. Sorry, yeah, I'll share it again and see, but hopefully
I can see it.
hopefully you can see it. That is important because you're seeing it is very important. Can you see my screen now?
No, sir. Actually, I'm on a Mac. Yeah, I can see it, sir.
You can see the screen now.
Yeah. Yes.
Okay,
Yes,
it's coming
yes.
now. So I'll
Right.
run it for you. Ask me to just move the slide.
Fine,
Yeah.
fine, sir. Yes. Okay.
Yeah.
This, what we usually do is called the traditional format, wherein the PG, the postgraduate resident, will select us journal, preferably after consulting with the guide or the staff, and then present. There is the other, just more answer. The more difficult one is the evidence-based, which is what ideally you should have done, wherein there should be some evidence to say that what you're presenting is actually correct. But there are 2 newer ones. The next one, sir, what is called the flipped, and the next one, sir, what is called the virtual online. These are relatively new. In the flipped version, there is much more involvement from the participants per se. What we're trying to do is that in that you send, as we go on through this presentation, tell you that the article must be given adequately early, such that the participants can prepare. So in the flipped version of the journal club, you find that the involvement of the participants also is more important, and they are held accountable. Can we move on, sir? What's the purpose of this journal club? Like has been repeated very often, the idea is to teach your residents what is called critical appraisal skills. Nice words. Basically, it means that you must know what you're reading is probably the truth and it's worth reading. Like our president, sir, said, there's so much of literature. So it gives you an exposure to this a large amount of medical literature. And to answer, we are hoping that it helps in clinical practice and help you in design some protocols. So this is ideal. At the end of a journal club, you can do, hopefully, all that what we said should happen. But sadly, according to this paper, which I picked up in 2017, many colleges, I'm sad to say, this is what happens. Neither the person who's presenting knows what's happening, The staff member is not consulted. And I love that first sentence. Sleeping juniors attending under duress. The first year PG has no clue as to what is happening. He or she has to attend because there's the HOD is sitting, and this is reality. We hope that today's journal club will be a little better than that. We'll go on, sir. There are basically, so you put the entire slide, it's not coming in order. You put the entire thing, sir. There are basically 3 sets of people involved in a journal club. That's the presenter, who's called the self, who has to choose the article and look at it, critical appraisal of the article. Once it's approved by the moderator, so here the staff member, send it to the participants well in time, and most importantly, read what is nicely called collateral reading, if you look at that box, and prepare a fairly decent presentation. Also important to look at the time, what is given. There's no point in having a journal club for 1 hour and you having 90 slides. It's physically impossible to go through so many slides in the stipulated time. What's the role of the moderator, the staff member concerned? You should ideally help to choose the article and supervise and check the presenter / the presentation. The participants also are equally important. We said you must have what is called the collateral readings. Critiquing an article takes a little time, and critiquing the presentation will come easier than critiquing the article. I must stress on the word critique here. Nowhere is it said neither the moderator nor the participant must criticize. There's a little bit of difference in English, but makes a hell of a difference for the person who's presenting the journal. Next slide, sir. Please go on, sir. That's the same. It's come. Yes, there was this article which I picked up on the 2017, which speaks about constructive criticism. And the next one, sir, wherein it says you must learn to criticize the journal. Sadly, many a time when the article is being criticized by the moderator or the staff, the concerned postgraduates think it is the criticism of the individual. That's not the idea of the staff, nor should it be the purpose of the journal club. Very easy to keep on saying that the postgraduate does not know. It's probably our duty to teach the postgraduate how to prepare a good journal, and more, the next step would be how to critically evaluate the article being read. Go on, sir. How to choose an article? There are certain good guidelines. Preferably, a new article should be less than 2 years, preferably not more than 5 years. Dr. Shivaram sir, the president, was speaking about the type of journals. You must have preferably an index journal with a good impact factor. It should be relevant and should have an impact on your practice. Like I've joked multiple times, no point if you have no exposure to vascular surgery, no point in picking up a journal which says how to cross-clamp the aorta during a dissecting aortic aneurysm. May make no relevance to me. And as far as possible, should be an original study, preferably a well-conducted, an RCTs or a large cohort studies. What you should avoid as far as possible are these: case reports, case series, retrospective studies, or a review articles wherein there is a chance for bias to creep in. What should be the presentation per se? It should contain a brief description of where you picked up the article, what is the relevance of that article that you picked up, and what is the basic research question being asked. It should also describe in brief about the materials and the methods. Keep going on, sir. The materials and the methods, the results, the statistics, which is scary, I must confess. As a prelude to this presentation, we're discussing with Dr. Ramakrishna, who's an acknowledged master of statistics, and I realized how little of statistics I know. I may be excused because I'm at the other end of the spectrum, but as a postgraduate, you probably need to know more statistics than what I need to know and have a conclusions. Also important to know about the strengths and the weaknesses of the study that is being presented in the journal. As I conclude, my last slide would be, at the end of the presentation, you must be able to answer these 4 questions. Is it new? Is it true? Is it relevant? And at the end of all that, should we change? And if your journal has answered these 4, probably I think that journal club is worthwhile. Thank you, and sorry for the technical glitch.
Thank you very much, Rajesh. We will move right on to the presentation of the Journal Club by Dr. Mahanaz. I now request Dr. Ramakrishna to take the lead in guiding Mahanaz with the presentation. Mahanaz, please go ahead, start sharing your screen. And Dr. Ramakrishna, please. Yeah.
Thank you, sir.
Yeah, thank you, sir. Good evening, everyone. I thank KSCASI and Dr. Lakshman for giving me this opportunity. Here, I'm happy to share with you that the chief editor of Indian Journal of Surgery, Dr. Sandeep Kumar, he has joined, but actually he wanted to join here in Zoom, but unfortunately it allows only 100 people. So when I asked the technical person, he said, you have to join through YouTube. So like many others, he's in the YouTube viewers list. I welcome you, sir. And as Dr. Rajesh has already given brief overview of how to conduct a journal club, how to choose an article, everything he has told. Only one thing I want to add here is for the postgraduate students and the teachers, journal clubs helps in choosing or finding new topics for the research and dissertation topics. See, here we keep on selecting recent journals, and when we discuss, we get so many unanswered questions, and those unanswered questions will become research question, and based on that you can design your study. So you get newer ideas and newer topics for your dissertation and research. So that is one of the most important things. A few things I want to repeat. See, the most important thing is journal club is a teaching tool for learning the art and science of critical appraisal, and the participants, they will get full benefit of the journal club if and only if they read the article, come prepared with their own critics, their own analysis, then only it will help. Otherwise, when we are talking about plus points, negative points, strengths, weakness, you go blank, you won't understand anything. Anyway, I hope all of you have read and come with the your own analysis. And please don't expect the postgraduate student or the presenter to give a lecture on this topic of rectal cancer. She will be highlighting only those points which are required for the analysis, and she will be pointing out what are the weaknesses or the strengths of the article. That is the critical analysis. That's the important thing. She has prepared a nice presentation, and I welcome her. And over to you, Dr. Manas. Please share your screen and start presentation.
Thank you, sir. Is the screen visible, sir?
Yes, you're audible and it's visible. Please go ahead, Manas.
I would like to thank Karnataka State Chapter Association of Surgeons of India for giving me this opportunity to present Journal Club. My moderators are Dr. K. Lakshman, sir, Dr. Ramakrishna H K, sir, and Professor Rajesh Ballal, sir. I'm Mehnaz, final year surgery PG from BMCRI, and I'll be presenting the Journal Club. The title of the article I'm presenting on is Laparoscopic and Robotic Surgery for Rectal Cancer. It's a comparative study between 2 centers. It was published in the Indian Journal of Surgery in 2021 in February. This is a peer-reviewed international journal which is Scopus indexed with an impact factor of 0.437, the publisher being Springer. It was published on the 8th of May 2020.
Dr. Mehnaz,
yes,
just
sir.
a second. Go back
Yes,
to the previous slide.
Ramakrishna sir, your volume is low.
Is it, sir? Now, sir?
Yeah, okay.
I have come a little nearer to the laptop. Okay. You said it's a peer-reviewed journal and impact factor of 0.43. What do you mean by peer review and what is the impact factor? What do you understand by impact factor?
So impact factor is a measure of the frequency by which the average number of times the journal has been cited in a year. And this is calculated based on the previous 2 years. So it's measured as the total number of times an article has been cited in the previous 2 years divided by the total number of articles which are citable in that journal in the past 2 years. So that value is given as the impact factor. Peer review is all index journals, they would be reviewed after submission of the journal, they would be reviewed by a reviewer. So that can be a single reviewer, a double review, triple review, or an open peer review.
Yeah, and is it always impact factor gives the quality of the journal? See, this is one of the quality measures of a journal. Impact factor, though it is less here, why did we select this IJS?
It also depends on which database the journal is indexed in. Like if it is Scopus indexed, or whether if it is Scopus, Medline or PubMed index, then we can also usually the good journals are
Higher
indexed with
what I wanted to stress is some of the journals, if you search online, they show impact factor of 4 or 5, something like that. But if you really look at the quality of the journal, it may not be as good. So it's not really completely foolproof. Many journals, they do so many manipulations to get a higher impact factor. So even though our IJS has got little lower impact factor, still it's a good journal. It is our journal. So we want to highlight our journal in the journal club. That's one important thing, because it is peer reviewed. We reject almost 50 to 60% of the articles submitted. That means the quality of acceptance is quite high with the Indian Journal of Surgery. That's why we are choosing our journal. Yeah, you can move.
Thank you, sir. The authors of this journal were, this article were Audrius Talksis et al. It is a bicentric study with one center being in Vilnius, Lithuania, and another center in Seoul, South Korea. The departments which were involved were general surgery, surgical oncology, surgical gastroenterology, and the type of study conducted was a retrospective observational study. This study was relevant because colorectal carcinoma is one of the most common GI carcinomas. Majority of these cases need surgery either for curative or palliative purposes. Minimal access surgery has been increasingly being used for colorectal surgeries because it's shown to have a similar disease-free survival and similar rates of local recurrence, just like open surgery. The advantages of minimal access surgery is that there's less post-operative time, shorter post-op hospital stay, there's a faster recovery of bowel function, and lower rates of wound infection. So this study compared two surgical techniques, which was hand-assisted laparoscopic surgery, HALS, versus robotic surgery for the management of rectal malignancies. In hand-assisted laparoscopic surgery, a sleeve appliance is applied to the abdomen. It maintains pneumoperitoneum. Surgeon's hand is inserted into the abdomen, and the rest of the surgery is conducted similar to laparoscopic surgery, and monitor is for visualization. The advantages of this is that there's a better exposure. The surgeon can give traction themselves with their hand. They can palpate important structures, and digital dissection is possible. So this is HALS being done. Robotic surgery, its advantages are that it improves the surgical precision because it has wristed instruments with 7 degrees of freedom. There's a stable 3D visualization that doesn't depend on an assistant, and it obliterates tremors. This is robotic surgery being done. The ports, this is total mesorectal excision being done via robotic surgery. The research question of the study was which approach is better for rectal cancer surgery, for in particular total mesorectal excision, between HALS versus robotic surgery. And their objective was to compare surgical and oncological outcomes between these two groups in the same HALS versus robotic surgery in total mesorectal excision in rectal cancer patients. The materials and methods, it is a bicentric and retrospective observational study. Cases were operated between August 2006 to December 2012 in 2 different hospitals, one in Lithuania and one in South Korea. But the analysis was done in 2015. Rectal cancer patients, where the cancer involved upper 2/3, underwent total mesorectal excision via HALS or robotic surgery, and they were reviewed prospectively. The patient's demographics, post-op short and long-term outcomes were assessed, and these were compared. This study included all patients above the age of 18 having primary rectal adenocarcinoma located within 6 to 15 centimeters from the anal verge, belonging to stage 1, 2, and 3 and ASA 1 and 2. It excluded patients who were unfit for surgery, ASA 3 and 4, disseminated or stage 4 disease, and patients who weren't willing to undergo minimal invasive surgery, and more importantly, tumors that were located in the lower 1/3 of rectum. The article claimed that patients belonging to both groups were matched according to their age, sex, and stage of the disease. The other variables that they included were BMI, comorbidities, length of cancer, estimated blood loss, previous abdominal surgery, intra-op complications, length of hospital stay, post-op complications, mortality, and histopathology. All the procedures were performed by 2 senior surgeons, and robotic surgery was done in South Korea. The HALS was performed in Lithuania. 78 rectal cancer patients underwent HALS with an average age of 64. And in the robotic surgery group, there were totally 62 patients with a median age of 54 years. The study included 150 patients, 10 were lost to follow-up. And on histopathological features, the findings that were considered were histology and type of tumor, the length of the specimen resected, distal and proximal and the circumferential resected margin, lymph nodes harvested and their positivity. The definitions according to this study, which was given, was overall survival was given as time from day of randomization until the day of death or day of last follow-up. And disease-free survival definition was given as time from randomization to recurrence or death due to any cause. For statistical analysis, Fisher's test was used for categorical data, and Mann-Whitney-Hughes test was used for continuous variables. Statistical analysis was performed using SPSS version 2017, and p-value less than 0.05 was considered significant. I would like to invite the audience for their critique.
Yeah. While we take the first question, Ramakrishna, I'll just check into the chat box with your permission. Okay. While we're waiting for the question or critique from the audience. Dr. Kavita Bhatt says, during my time, only review articles, mostly narrative, used to be discussed. Ma'am, the idea, as we said, is to be able to critique the materials and methods. In a review article, you can critique the way the articles are chosen and whether it is a systematic review, conforming to the PRISMA guidelines or not, and things like that. But ideally, for any journal club, particularly for the beginners, it would be nice to ease them into the process of critique of materials and methods, which means an original article. So we would recommend that we use original articles for this. Next, when should PGs present journal club? First year or second year? They should start in the first year. They need a lot more hand holding in the first year. And as they get the experience of doing more and more of these journal clubs, by the time they come to the third year, they become pretty good at it. Okay. Does impact factor get affected by year of publication? Year of publishing? No, it doesn't matter on the, it takes into consideration, as Mahana said, the number of times it is cited in any 2-year period. It is calculated in cycles of 2 years. So year of publication itself would not really matter. All right, Ramakrishna, over to you, please.
Some more questions, Dr. Lakshman.
Okay, I have
So,
I can't see any more in the chat box as of now.
Okay, shall I read them out?
Please, please.
Sangamesh is asking criteria for accepting this retrospective study in a journal like IJS. That is editors.
Can we skip it now? Because that's, yeah, we will discuss it perhaps privately afterwards. Yeah, thank you.
Kavita Bhatt is asking, could the outcomes slide be shared again, please? The outcome slide. Can you share?
Outcome, we have not come to the outcome slide. You
Outcome
mean
is not
the
good.
materials? Mana,
The
just go
parameter
back.
studied.
Parameter study. Just go back 2 slides, Manas, please.
Yes, sir.
Still in the material.
Variables which are included. These are the parameters.
These are the
that have
variables, yeah.
taken into
Parameters, yeah.
Okay.
Okay, so now I invite all the audience to give your inputs. What are the flaws or the weaknesses in the discussion so far done? We have not yet gone to the result section. Till now, whatever I presented. So in that, if you find any weakness or the strengths, the positive points, those things you please highlight. One by one, you can unmute and tell or put it in the chat box, and we will see.
Dr. Sangamesh is telling it's a retrospective.
Retrospective study, yeah.
Yeah. Well,
Okay.
Is it a positive point or a negative point for this study?
Sangamesh, you can unmute and speak. Dr. Sangamesh.
Yeah, and Nas says 2 different, yeah, it is a negative study, right? Negative point that it is retrospective. 2 different centers with different surgery. Yes, how would that impact Nas according to you?
That's the idea.
They are comparing the 2 different surgeries. So surgeries being different may not matter, but 2 different centers, it does matter, particularly in this study. And I was just curious, how would you say it impacts either positively or negatively?
Dr. Nas, please unmute. Okay, till then we'll take up the next
Okay.
question. Is HALS standard procedure to be compared? And Dr. Sopimat is asking.
Yeah.
Is it a question, sir, or a comment? It's a question. Yeah.
Yeah. HALS is pretty much a standard procedure. Many people, when they do these major resections, use a hand-assisted surgery. So, not very commonly practiced in this country, but it's quite popular elsewhere. So it is a standard procedure, at least in some centers. Yes.
2 more comments.
Have they undergone neoadjuvant chemo?
Yeah.
And where they're following the same regime.
Yeah. Manas, do you want to take that question?
Yes, sir. Sir,
Yeah.
for cases which were T3 and T4,
Yeah.
and with node positive cases, they underwent neoadjuvant chemo, and after 6 weeks of neoadjuvant chemo, they were then planned for surgery and then operated. But all this was on previous hospital records.
Yeah, but the 2 centers followed pretty much the same protocols, neoadjuvant chemo. That was not a confounding factor. But Pramil makes this very important point. Yes, it's not just 2 different centers, but they're 2 different populations. The genetic stock itself is different. So you would expect the biological behavior of the 2 cancers could be different. That's a very important point. Yeah, that's right.
So what are the strengths then? People have been giving what are the weaknesses of the study.
Yeah.
Audience, anybody is finding out what are the real strengths of this study? What are the good points? See, critical analysis is not only criticizing, you should also bring out what are the strengths or good points in the study, so that will help you to incorporate them into your own study.
Yeah. Can we go ahead with our critique slide, Ramakrishna? We're only about 20 minutes left. Yeah. Go on, Manas.
Yeah, now, Manas, please go to next slide.
Manas, please go to
So after going through the audience inputs, Now, these are what we have found, and Dr. Manas will tell you about that.
The positive aspects we found in this study until now was that it was a recent paper, and the study protocol was specified. There was a clear objective. There was clear inclusion and exclusion criteria. It was conducted by experienced surgeons, and it had a novel idea. It was one of the first studies of its kind.
No, actually,
The
Sir?
negative.
Any comments from
Yeah.
the audience regarding this?
sir, yeah. Ramakrishna, can I come in?
Yes, ma'am. Yes, sir.
I don't think this is one of the first. I think there are many studies which compared laparoscopy versus robotic surgery, not maybe HALS, but robotic surgery with the roller, the classic roller study, ROLORR, which is actually considered the benchmark for all comparisons between laparoscopic and robotic surgery. It reported in 2017. So I don't think you should say that this is one of the first studies.
No, we were considering HALS here, Ravi.
HALS.
We were considering HALS. Not many people do HALS, and that is why we're considering HALS in this.
Yeah, okay.
Okay.
No,
These are
but
the
Dr. Ramakrishna,
Yes, sir.
see, the data is from 2006 to 2012,
Yes, sir.
and it was analyzed in 2015. So don't you think it's now we are in 2023? How
Yes,
do you say it's a recent paper maybe, but not we are quite back in that technology, and also robotic, what is being done now is entirely different what was those days.
Yeah, that's a point well taken.
That's a
Yeah.
point, sir. But sometimes what happens if you want to have 6 or 7 years follow-up, then the data naturally becomes old, sir.
Right. All right, move on.
Yeah. Next slide.
Yes, sir. The negative aspects in this study were it was a retrospective study. The cost of hand port and robot.
Dr.
was in-
Kalayani is asking what is the level of evidence when you consider a retrospective study? What is its weightage in the evidence pyramid?
The level 5 goes for RCT. Level 4 is for a prospective
No.
study.
RCT is not level 5.
Level 5 is for meta-analysis. sir.
Meta-analysis and
Meta-analysis.
reviews. Yeah.
Level one,
Systematic
sir.
reviews.
Level 1.
When we are talking about
It's
level,
level one.
yes,
Well, the other
level
way.
1.
meta-analysis
No,
and
yeah,
systematic
it's the other way around. The best is level
Other way
1,
around.
which is
Sorry.
meta-analysis and
RCTs.
systematic reviews and RCTs. Yeah.
This will be level 4.
Large cohort studies will be level 4, and
Level-
retrospective studies would be level 3. Level
Yes, sir.
2,
Retrospective studies are better than case series and
Case series.
opinions.
yeah,
Expert
which is
But they
level
are
2.
inferior to prospective study.
Yeah, case
Level
series is
4, I
level
think.
2. No, this is level 3. Case series are level 2, and sorry, level 4. I put it the other way around. Case series is level 4, and the least, which is level 5, is opinions.
Expert opinion.
Expert opinions. Okay, so
Case
this would be level
reports.
3.
Experimental
Case
evidence
reports.
also sometimes they give. That
Yeah.
one carries the low. Case report is slightly
Case
better than expert opinion.
Yes,
Okay.
that is level 5, sir.
Yeah.
Ramakrishna
Why do
will
you
move
think
on.
Level 5.
Ramakrishna
do you
will
think
move
the-
on.
Yes, sir.
Negative
Why do you
aspect.
think the cost of the hand port and robo, which is not mentioned, why do you consider it as a negative point here?
Because the that also comes into picture for the overall. We are considering various variables, like
Yeah, when we are comparing HALS with robotics,
HALS
I
was
think
with
cost
robotic
factor
surgery.
we must take into consideration to say which is better ones. That's why. And the paper claims it is a multicentric, but actually it is a bicentric, not multicentric. The
Yes.
other thing is the follow-up protocol. Why do you say it is not the biological difference? I think it is already discussed. So we'll go to that follow-up protocol. Did they mention the exact follow-up protocol? When patients should be followed up? How long they should be followed up? All those criteria have they mentioned?
No, sir. There was no clear protocol for follow-up.
Yeah, and one of the outcome they are studying is the disease-free survival and overall survival. For this, the follow-up protocol is very, very important. They should strictly mention how patients are followed. It is not mentioned in the article, so we consider this as a negative aspect. They have excluded the lower third rectal cancer. Is it a problem here?
Yes, sir, because lower third rectal cancer is where robotic surgery comes into picture as one of its advantage, because
Yeah, it
it
scores over there.
yes, sir, it can reach into, especially in male pelvis, where it is difficult to reach, and the lower for lower rectal cancers, this gives a better visualization, and it's more
Means,
accessible.
the robotic surgery is better for lower third malignancies. When they have excluded that, definitely the data will be negative on robotic surgery. And intraoperative findings, post-operative complication based on the hospital record. This is a retrospective study. It's a negative point already discussed. And intention to treat principle is not followed. What is intention to treat principle, and why?
Intention to treat principle basically helps in decreasing bias, sir. So in the beginning of the study, the number of patients that we consider for doing this study, it should, if we follow up and keep, and the same number is calculated even for the results, then we are following intention to treat principle. If some of the patients have lost to follow up, or have been taken out of the study, that would influence the results as well. So when intention to treat principle is not followed, then the bias increases.
Yeah, what they can do, the patients with poorer results, they can just exclude from the study and show that data or the results are better with one particular group. So if you have started with 100 patients till the end, that is, while analyzing also, you must account for all the 100 patients. If two groups have got 100 patients, one group you have lost 10 patients in the follow-up or death or complication, whatever. Another group has lost only 10. Then at the end of the study, you will be left with only 80 and 90 patients. So if your mortality is 5, say, then the mortality rate is not 5 by 80 or 5 by 90. It is 5 by 100 if you follow intention to treat principle. What is the other type of analysis you have? In contrast to ITT, we call it per protocol or modified ITT. There, whatever patients left at the end of the analysis, only thus will be taken. In the same example, what I was quoting, the mortality rate becomes 5 by 80 for one group, 5 by 90 for the other group. If you follow ITT, for both the groups, it is 5 by 100 because you have started with 100 patients in each group. So if you follow per protocol, what happens if some patients do not have good results, you can exclude them and show better result for one of the groups. That means there is a bias. To avoid this bias, ITT principle is applied. And when you follow this, the study is said to be superior. And method of calculating the sample size is not mentioned. How to calculate sample size? What is main defect in the outcome they have mentioned? No? What is that? Could you make out that? See, they have mentioned so many parameters as the outcome measured, but they have not mentioned what is the primary outcome. Yes, so you have to have one primary outcome and many secondary outcomes. Secondary outcomes may be 1, 2, or 5, or whatever number you want, but primary outcome should be 1 because based on the primary outcome frequency, we are going to calculate the sample size. That exercise is not at all done in this study. What is the required sample size is not mentioned. They have not even tried to measure that. That's a negative point also. And Fisher's test cannot be applied for some data. What type of data Fisher test cannot be applied in this study?
If it's more than 2 into 2 table, anything like 3 into 2 table, then it cannot be used for some data. For example, the recurrence in the study was in 3 into 2 tables, which Fisher test cannot be applied for. Chi-square test would have been better.
Yeah. So if you have a table with 2 into 2, then you can use either Fisher test or chi-square test. But if you have 2 into 3, I think one more table is there. It is 4 into 2. So for
Yes, sir.
such tables, you cannot apply Fisher test. In the statistics, they have mentioned only Fisher test for categorical variables, which is not possible. They must have used chi-square test or some other test which is appropriate for that, but they have not mentioned it there. So it's a defect there. They should have mentioned it. And they have mentioned some matching of the age, sex is done. They have mentioned in the methods.
Text.
But
Yeah.
actually, they have not done it, because whatever patients with this said inclusion and exclusion criteria, everybody is included there. They have not tried to match. What is matching? Dr. Menas, can you explain?
Yes, sir. Matching helps when we match two groups, we have to exclude the confounding factors and we match them to the same age, sex, and here they claim to have matched them to the same age, sex, and stage. So when they're comparing the patients, they should be comparing this patients belonging to the same age group, the same sex, and the same stage in both the groups.
No, that has come in the end. That's a different thing. Matching, if you are intentionally doing, if you have a patient with 50 years age, there can be different criteria. I'm taking age as the criteria. If you have a patient with 50 years age and put it in one group, you should also have one more patient with the same age in the other group. That we will be doing intentionally. Hello. Please mute it. Yeah, I was repeating. If you have one patient with 50 years age, you should also have another patient with the same age in the other group. Like that, you have to match for everything. It may be sex or staging of the disease or maybe any other criteria. So based on those criteria, you must match. That exercise is not done in this study, but they have written matching is done. This is not acceptable. So we have put it in the negative aspects.
Ramakrishna,
Yes,
Ramakrishna, one sec. Dr. Sandeep Kumar has logged in. I'm very glad that he has joined us. Good evening and welcome, sir.
Thank you.
Please go ahead, Sandeep. Please go ahead. Yeah.
No, I just wanted to say something. This is not a trial. This is not random distribution. This has been done. These are a comparative study of two discrete case series done in two countries. One type of surgery is being done in Lithuania. One type of surgery is being done in Seoul, Korea. So it's a case comparative study. It's not a retrospective study. It is wrong to call it a retrospective study. It has been prospectively planned like that. So they're wrong to say that it's a retrospective study. The matching, as was being commented upon, has not to be, it is in epidemiology these days, very strict matching is considered not very good because in real time, perfect matching doesn't take place. So near matching is good enough in terms of comorbidities, as far as case selection that all upper 2/3 cancer rectum has been taken. So I'm happy with the matching. And I'm not happy to call it a retrospective study. The investigators in Prospect have thought of comparing their results and have been careful to do certain, amount of outcome measurements on the line while they've been following up these patients. That's all.
Yeah, Sandeep, I have two comments to make on this. One, they claim that it is a prospective study, prospectively developed, maintained database, but there is no protocol for follow-up. So when they talk looking at outcomes, disease-free survival or overall survival, we do not know how often they saw the patients in the outpatients and what was the protocol that they followed.
They should have a very strict third-party follow-up, protocol-based follow-up, and that's the sign of any study.
Correct, and that's why we felt that it has all the limitations of a retrospective study. And number two,
I would agree with that.
Number two, even in the old population, even in a retrospective study, if they had done a formal propensity score matching, which is now considered pretty standard, then they could have claimed that it is matched. In this case, we have no mention of propensity score matching done. And that's why we felt that perhaps it's not as well matched as it should be.
I would agree that.
Go ahead, Ramakrishna.
So there is a small doubt in the chat box.
Yeah,
ITT
we will,
is only for
we will go through this one bit
Fine,
and then we'll come to the chat box, Rajesh. Yeah.
You have to
Ramakrishna,
make it
please.
quicker.
Yeah, we are really
The
running
other
short of
thing
time.
is-
It's very
Yeah.
nice that we have a great discussion, but we are running short of time. Yeah, go on. Yeah.
Ramakrishna, a little faster.
Yes, sir. So the central,
results
by
now.
presenting the data, the central tendency, we use so many factors like mean, median, or mode. Here what? Yeah. Here what they have done, they have used average or mean as the central tendency parameter for Hall's group, and they have taken median for the robotic surgery group, which is not acceptable. They should have used mean for both or median for both. So this is a negative point. I just want to clarify, mean we use when we have parametric data, the data which follows normal distribution curve. They are called parametric data. If you have data like that, you must use mean. If your data is non-parametric or the skewed distribution curve, then you must use median as the measure of the central tendency. But if you use one in particular group, for the other group also you must use the same parameter. One group you use mean, for the other for the median, it's not acceptable. And definition of OS and DFS, that is the overall survival and disease-free survival. Dr. Manas, can you tell what is the problem with this?
So the
Why you have mentioned
the
it as a
definition given in this, the definition of overall survival and disease-free survival in the study was wrong, sir, because it gave as overall survival as from the time of randomization till the death of the patient. But the actual definition is from the time the disease is diagnosed or the primary treatment is started until the patient lives, like until the death of the patient. And disease-free survival also the same
And another
mistake
problem
was
is
made.
they say it is.
Sir?
Yeah, another problem is they say from the date of randomization.
Yes, so
Another problem with that
the
definition is from the date of randomization, they say, but
Yes.
actually randomization is not at all done in this study. It
Yes,
is
sir.
just all the patients they have taken. There is no randomization and they cannot use this definition. That's the problem with that. And they also have said some censoring of the data is done.
Yes,
Is it
sir.
acceptable for calculating the overall survival?
No, sir, it's not acceptable here. It's acceptable in KM plot, but
Yeah.
when we're thinking about overall survival and disease-free survival, it's not acceptable for censoring data.
Ramakrishna, if
Yeah,
I
when
may
they
go
mention
into
the overall. Yes, sir.
Go on, please. Finish that. Go on.
Yeah, just I wanted to tell what is this censoring of the data. See,
Please.
when a patient dies or he is lost for the follow-up or he is removed from the study because of developing some complication or something, then that patient data is no more available from that period onwards. So if you remove these things, we call censoring of the data of that particular patient. So when we are calculating the overall survival or disease-free survival, we must know what happened to all the patients who are in the denominator or the numerator of the calculated ratio. Censoring if you censor some of the data, there will be discrepancy. The next few slides, I will be showing that what is the discrepancy, why that is not acceptable. Sir, any comments other than this?
I'll take
So
the
I think
comments
we
in
finished
the
with this critical.
Ramakrishna, can I take the comments in the chat box, please?
Yes, sir.
Yeah.
Yes, sir.
Yeah, okay. I may not be able to answer every one of them, but I'll take the ones that are generally not addressed in this in the discussion so far. Do we have to explain about the basic topic on which we are presenting, or can we directly go to the article itself? By and large, we should go to the article itself. Now I do not think in this particular case, for example, we should talk about rectal cancer or robotic surgery or laparoscopic surgery in detail. We have to go to the article itself, because the time there is only for the critique of the article. Subject proper either it is robotic surgery or cancer rectum or whatever, will be covered under the other conventional teaching tool, which is subject seminar. Okay, is the sample size adequate? No, we have addressed that. It is not done. Intention to treat, is it only for RCTs? Not necessarily so. You know, when we were preparing for this, we had a discussion with Mehanaz also, and we looked up the literature, and intention to treat can occur in all kinds of studies. It need not necessarily restricted to RCTs. Sandeep has already vocalized. Yeah. Okay, I'm just going through this. There is a selection bias, more mid-rectal in robotic surgery arm than Hall's. Yes, that will come up in the results section. We have not reached that part yet. Can the discussion be at our level for the lesser mortals? Extremely good point. I was actually going to make this in my closing remarks, but Sadashiv Sopimat has now stimulated me to make the remarks now. Now, this is a demonstration of a journal club the way it should ideally be. That's all I can say. And as Rajesh said in the beginning, you need the expertise of somebody like Ramakrishna to match this. I personally don't have that expertise, and I always depend on Ramakrishna's comments to help me with it. But this is the important but. Every journal club need not be at this level. The statistics need not be discussed at this level. You know, there are always, you must know about the basic statistics. Statistics need not be discussed at this level, but the materials and methods, patients and methods, the methodology, randomization or whatever, parameters used, outcomes, you know, things like what is a primary outcome. You cannot have 10 primary outcomes. So those are the things where you do not need in-depth knowledge of statistics. And if you understand those aspects and perhaps not get overwhelmed by the high level of statistics that we're discussing, that is good enough. But if you are in a center where people, when you have the expertise for that kind of statistics, perhaps you want to have a statistician sitting next to you, you can take the statistics to that level. What is propensity? How to check? That will be a different discussion. I'll skip that. Yeah. Can this study be called a retrospective study? Yeah, it could be. It could be. Nice presentation. Yeah, that's fine. That's as far as the comments are concerned. Can we move on to the next phase, Mahanas, please? Please go ahead.
Yes, sir. The results of the study, there were a total of 150 patients who were included in the two centers. 10 of them were excluded due to loss to follow-up. The male to female ratio and stage distribution of the disease was similar in both groups. However, when we compared the HALS versus robotic surgery groups, it was found that upper rectal cancer was constituting totally 94.9%, majority of the patients in the HALS group. And in the robotic surgery group, it was mainly middle rectal cancer, which constituted 64.5%. And the operative time in the HALS group was, the average time was 106 plus or minus 37 minutes. And in the robotic surgery, it was 321 plus or minus 70 minutes with a significant p-value of 0.01. But as we saw earlier, majority of the patients in HALS group belong to upper 1/3 rectal cancers, and in the robotic surgery group, it belonged to middle third cancers. The groups were statistically the same for the size of tumor, the quality of mesorectal excision done, lymph node count, and staging. There was a positive circumferential resected margin, which was positive in one case, which was in the robotic surgery group. Mortality in both groups was nil. And the overall survival and disease-free survival in both the groups were almost the same. In this, I would like to highlight that as we discussed, the operative time was more in the robotic surgery group compared to HALS group with significant p-value of 0.001. But recurrence in the HALS group was total cases of 7 out of 78. And in robotic surgery, it was 15 out of 62. and the p-value for this wasn't calculated in their statistics. The study concluded by saying that robotic surgery and hand-assisted laparoscopic surgery were both oncologically safe procedures. And although a large multicentric prospective study groups with long-term follow-up data are needed, robotic surgery is limited with its long operative time. Ethically, this study was...
You can skip this. There is nothing
Yes, sir.
much in that. You can skip this slide.
Yes, sir. So there was no conflict of interest.
No conflict of interest. Go to the next slide.
I would like to invite the audience to give their critique.
I think why have I selected this study to publish? Firstly, I mean, I don't read. Am I being audible?
Yes, yes, Sandeep, please go ahead.
It's a very tedious and arduous job doing journal and reading every article to the depth when you have very tardy people. I'm very, very grateful to all three of you, Shivaram, Lakshman, and Ramakrishna, for being good Samaritan at reviewing process. But I thought I have recently published an editorial also that landmark studies and corner turning practice change has not come from randomized studies. They have come from case series. People, in fact, laparoscopic cholecystectomy got established even before a randomized trial between open and laparoscopic surgery was done, and 2/3 of gallbladders were being removed laparoscopically in America, and there are many such studies. So actually, practice change does take place, and same has happened with robot. And this actually stimulates people to do more and more tight randomized studies. And this was a study between two countries. It was case comparative study, and reasonable matching was there. So those are the points I think, and I thought were favorable. And that is why we accepted this paper to be published. And I'm very grateful to the Karnataka Surgeons Association to have taken up an Indian Journal of Surgery paper for critique. I'm very happy to be participating here this evening. Thank you very much.
Thank you. Thank you for joining us.
Thank you, sir.
Yeah. Ramakrishna,
Sir, we have
can you just
Yes,
go
sir.
with the critique, and then, we'll give because of lack of time, we need to proceed.
Yeah.
So,
we will
put the critique and then invite comments on that from the audience. And I'll also monitor the chat box. Yeah.
Okay,
Yes, sir.
you can put in the chat box. So for want of time, I will just go a little hurriedly. See, here the positive points are the objective, what they have started with, and conclusion, what they have given. Though there are some limitations, they correlate with each other very well. So that's a good point in this study. And they have assessed various short and mid-term oncological outcomes. Results were specific and well represented in the table. Only defect, as she already mentioned, the p-value was not calculated for recurrence rate. That's the main defect there. And this is first of this such studies which is comparing HALS with robotics, as the authors claim. And they have also identified what are the limitations of their study and how it should be corrected in future research. Those things the authors themselves have identified and mentioned. It's a good point. And next slide. Next slide.
Yeah, it's coming now.
Yeah. Regarding the defects or the not so good points, the level of cancer is different in two groups, and two groups are ethnically different. So these two things makes together one question: are they comparable? Whether these two groups are comparable. The basic concept in research methodology says you should compare apples with apples and not with oranges. So this violates this. And the second thing is the follow-up protocol is not mentioned, the primary outcome, these things we have already discussed, I think. In the conclusion, they have just given the conclusion. They should have added one more sentence in that conclusion, that so-and-so conclusion in cases of upper 2/3 CA rectum in stage 1, 2, 3. That because they have excluded the carcinoma, lower 1/3, and also stage 4 disease. So while giving conclusion also, you must mention so-and-so conclusion in patients with carcinoma, rectum, stage 1, 2, 3, and upper 2/3. They have not mentioned that. The results cannot be extrapolated to this group of patients. That's one thing. And results are not matching with the conclusion. Can you go back to that result you showed just now? I will just show you how this censoring has affected the data. Please go to back. One more back. Yeah, here you see they have mentioned this. No, that slide on. Next one, DFS.
So
Next slide. Next. Here. Stay there. Stay there.
Yes.
Previous slide. Previous slide.
the table, sir.
No. I said you stay there. You clicked once again. Go back.
This one.
Previous slide. Previous slide. Previous to this.
Yeah,
No. You went too back. No.
this is
Next.
DFS.
It's okay, Ramakrishna,
Previous.
just mention what you want to say. It's okay.
Stay there.
We'll
Stay
look
there.
at it.
Stay there. Yeah. Here they have mentioned disease-free survival 83% in both the groups, more or less 83. So if this is the case, then recurrence rate also should be same in both the groups. Go to the next slide now. Next.
Next slide, sir.
Here you see. Yeah, no, enough. Stop there. Here the recurrence rate is 7 here. That is 9% in Hall's group and 24% here. When these two are differing, how disease-free survival can be equal in both the groups? This is one question. The second thing is they have not calculated p-value for this, and they say both groups have got the same result. And we calculated the p-value for this using the Fisher's test. Go to that critic. And it came less than 0.05, which was very, very significant. That is to conclude that the RS group here, the last line you can see. This is what we calculated, p-value. There is significant difference between the recurrence rate of these two groups. RS group are inferior with respect to this. So the conclusion, whatever they have given, is not acceptable. This RS group has got, RS group is inferior as far as these results are concerned. This is what we wanted to tell. And any inputs from the audience?
Yes. Can I quickly say one
please,
sentence?
Please go ahead, Sandeep. Yeah.
I mean, great exercise, Ramakrishna. Hats off to you. You've done the p-value and you've pointed out. But one more thing I must point out, and therefore I would not go into details of statistics doing it, is a huge case selection bias. As you said, these are two ethnically different groups in two different countries. And they don't tell you how many rectal cancer came to their hospital during that period, and how many they picked up to do robotic surgery or Halls, and how many they did not do by Halls or robotic surgery in their respective centers. So I take with a pinch of salt that all these studies, when they don't tell you the denominator of their numerator of 150 patients, that how many actually came, how many refused. When you do it, as you very rightly said, in an intention to treat analysis, which is done for case series as well nowadays, all patients who are intended to be treated must be included. Otherwise, you should have a very strong points to exclude them. So therefore, at the face value, these studies have case selection biases, and I would take the results only as a formative research for future randomized studies.
Right. Absolutely.
Yes.
Point well taken, Sandeep. And that would be our conclusion too, as you will see, go along. Yeah. Go ahead. So we are a little running short of time, Ramakrishna. So I think we'll have to rush through this. Manas, quickly go through the collateral reading and then we will conclude. Yeah, please go ahead.
Yes.
Manas?
Yes, sir. We did we went through similar studies which were done by Lam, J et al. And Liu C et al. It compared robotic versus laparoscopic surgery, and it showed similar results in both the overall oncological outcome, but it said that robotic surgery was preferable in lower rectal cancers, mainly because of its better accessibility. And studies by Haley et al. Showed that laparoscopic surgery and robotic surgery, open surgery was almost the same in both obese and non-obese patients. And Hennigan et al. Showed that it compared HALS versus laparoscopic surgery, and it showed that HALS was easier to do and it was faster, and it had lesser conversion rates. There was a meta-analysis that compared robotic surgery and all other types of surgeries like laparoscopic, transanal, and open surgery, and that showed that robotic surgery took longer to do, but it had better results. And the study by Warren et al., which analyzed various techniques again for total mesorectal excision, showed that minimal access surgery and open surgery had similar oncological outcomes. So to critically appraise this article as a summary, the study question was relevant and original, and it dealt with two newer modalities of treatment for a common and important surgical condition. And study didn't add anything new to the current guidelines. There was no clear basis for selection of their patients, and if it was a prospectively collected data or more would have been more appropriate to answer this research question, preferably a randomized control trial. And this study had selection bias. There was no evidence of addressing the confounding factors by propensity score matching. The results didn't correlate with the conclusion. So we can't recommend any changes in the current patient management based on this study. These were my references.
Thank you, Manas.
Thank you, sir.
I will address the questions and comments in the chat box over next 2 to 3 minutes, and then we'll conclude.
Manas, you can stop sharing.
Stop sharing, yeah.
Thank you, sir.
Journal club for the first year PGs, will they be able to understand the terminologies and things like that? Yes, you have to, as I said, it needs a lot more hand holding. But our first year PGs start off with studies, and we give them simple studies and spend more time in explaining the basics of the terminologies and the methodologies and things like that. And the third year students take a little more complicated subject. Guru Shartapa sir says, since the proper disease is not discussed in JC, the audience postgrad need to be knowing everything about the disease. Hence, is it JC needs to be done by third year postgraduates? Yes, as I said, it can be done by everybody, and this will be an opportunity. A journal club on rectal cancer, for example, will be an opportunity for the first year student also to read up. Obviously, his or her level of knowledge will not be the same as a third year's, but it would be an opportunity for them to read up about rectal cancer. Is the primary aim of JC reading is to have critique of the article? Yes, the primary job of a journal club is to understand critical appraisal, and they must be able to know the good points and the not so good points about the article. Ravi Shankar makes the valid point, which we had said, QOL and cost analysis is very important. It was not done this. In future, please put slide numbers. Yes, you can then tell them which slide to go to. Australian study shows open surgery better than lap, better than robotic surgery. Yes, there is always a debate, but you will find the robotic surgeons very strongly disagreeing with you on that, and with me as well. I don't do robotic surgery, but they will have their own data, and that is a part of life. Is a checklist being followed for the critical appraisal? Yes, by and large, yes, not in the same order or perhaps the importance as was listed elsewhere. But yes, this particular critical appraisal that Mahana has done has followed a checklist and it has ticked all the boxes that are required for doing a critical analysis. So my concluding remarks, again, thanks for a very active and a very nice participation from juniors and seniors alike. I'm sorry that we didn't have many questions from the postgraduates. From next time, I urge all the postgraduates to come out with their questions and their comments in the chat box. At least if you're not feeling happy enough to unmute yourself and talk, please put it in the chat box. Again, I go back to the very valid point that Sopimat made. This journal club gives you a window into a very good level of journal club discussion, and that actually perhaps is a discussion among consultants. It should not put the postgraduates under pressure to say that that they cannot do it. You can always make a beginning. You do it at your level and your comfort level and your degree of expertise. And as you move on, you will improve. And the only way to learn is to keep doing it and keep improving every day. Thank you again very much, and hand it back to Dr. Shivaram. Thank you. Or Dr. Chandrashekar. Thank you.
Thank you, Dr. Lakshman. That was very nice of you all to put a lot of hard work. I know that you have all done a lot of background work to make this program a grand success. And more than 150 people have logged in, including the YouTube. That's a very good encouragement for us to organize. I am very happy that editor of Indian Journal of Surgery, Dr. Sandeep, really participated, gave his comments and advice. I request Dr. Siddesh, our immediate past president, to give his comments. Dr. Siddesh, please.
Yeah, good evening.
Thank you for joining.
Shivaram, I think, yeah, good evening. Thank you for asking me to give comments. I think I should not be again diluting all the quality discussion which has gone on. I would just add few things otherwise, but I think this is time we conclude. But this exercise today has really gone on very well. I should congratulate the moderators and the faculty. They have done the talks up to the mark, totally 100%. And of course, our master moderator, Dr. Krish Lakshman, has taken the level to the highest, and also has told you need not have to follow every verbatim how the way this has been conducted. As he told, we may not have an expert analyst like Ramakrishna and himself all the time available with us. So anyway, we can always try to achieve the best. And so nice to see our editor-in-chief joining in. Sandeep, thank you very much. That also gives a scope, and you can always feel Karnataka State Chapter is doing a good academic work. Thank you very much. And I should not forget to congratulate the person who presented, Dr. Mehnaz. You have done an excellent job. That just goes to say there have been a lot of preparation efforts being put in. That is again commendable on the part of the faculty. Thank you very much. And I congratulate the chairman and the secretary for their work. Wonderful.
Thank you. Thank you very much. So next, our program is on 27th of April. That is my passion other than surgery. So how to de-stress. I'm sure many of you will be participating. I request everyone to join and enjoy that session. I'm sure that will be very, very wonderful session. Dr. Chandrashekar, you agree? You want to invite everybody?
Sir?
You want to invite everybody for the next session?
Yes, sir. And we have one HOD interaction with our Vice Chancellor and NMC member also, 18th.
That is coming on Tuesday.
Tuesday.
So we are having a lot of programs. Yesterday, we had a website committee meeting. So next, we are having an interaction of the HODs with the Vice Chancellor and the NMC member, Dr. Ramesh.
Ramesh.
Yeah, that is on Tuesday. That is for HODs. Thank you very much. Thanks for staying for such a long time. And